Yes, boys, good morning. Now, in continuation of my previous two classes on principle of fracture management, I am continuing this class to tell you about the fracture management, how you will manage. You have diagnosed it, you have investigated it, now how you manage it. You can divide this into three: emergency care. You are sitting in the emergency department and patient lands to you, then first aid should be given in emergency. Then there is a definite fracture treatment. This will be taken care by orthopedic specialist, and then once the fracture heals, how to rehabilitate this patient. The first most important is you have to splint it, because splint is the best painkiller. If you immobilize it, patient will be relief of lot of pain. Of course, you have to see the parameters of vital parameters. If it is not a serious trauma or polytrauma, the management of polytrauma is different. So I am not going to cover that aspect. So you have to splint that limbs, try to give little traction, and you can apply the available splint. I will tell you the types of splint are available. Why this is desirable? Because the pain relieves the pain and improves the circulation. Because if the bone is angled, it can injure the vessel and nerves. The goal of fracture treatment is to obtain union of the fracture in the most anatomical position compatible with maximal functional return of the extremity. So this is our aim. It could be conservative or operative. Many fractures can be treated conservatively depending on the displacement, how much is the displacement of the fracture and how stable it is. And then if they are grossly displaced and they are unstable, then you may think for operative. In conservative, you have to reduce. If there is displaced, minimally displaced under GA or local, brachial block, you reduce this displaced fragment. Sooner you reduce, better it is for the soft tissue. If you don't reduce it, there will be, because of the angulation, the vessels are kinked and patient will have a lot of edema later on and soft tissue problem. This step of reduction is attraction and align the fragment. By the normal anatomy, and then by this you can have the idea whether the limb is aligned or not. Usually in a step of reduction, if patient is under GA, you have to reverse the mechanism of injury and then give attraction, and then you can reduce it. Immobilization can be done by plaster slab. I will recommend in upper limb or use the plaster slab, because after initial trauma the swelling is less, but when the time passes the swelling will increase, and if you apply the cast which is solid all around, then patient may develop compartment syndrome. In lower limb, like in fracture neck femur or trochanter, you can apply a traction, and then you have to rehabilitate. Now, can you tell me about this patient? Patient is What is this? Patient is under anesthesia in OT. There is a plaster is applied above elbow, and this is a plaster cast is applied after reduction. This is a photograph of in emergency case. So, close reduction and displaced fracture, and treat it close if it is reducible by conservative treatment. And this is the below knee cast. You see, this is the fracture. It's a closed fracture. There is no wound. There is a swelling over the left leg, ecchymosis, and this is the X-ray of taken. And this shows wedge fracture, spiral wedge fracture. This is the tibia, this is the fibula, this is the ankle joint, and this was reduced, and a plaster was applied, a bony plaster was applied. What is plaster of Paris? Slab or splint? This is the diagram which shows you how to apply. With plaster of Paris bandage, you have to make a slab of 10 to 12 layers of the bandage slab. You have to dip in water, and then you have to apply after a cotton padding. This is the figure of traction. This is Galos Correction. If child is less than 1 year old and there is fracture shaft of the femur, this is a type of traction can be treated. This type of fracture, this is also known as Galos Correction. And this is a case where the fracture is at the hip. You cannot apply plaster. In such cases, then you have to apply a traction for temporary relief till you plan for surgery. These are various types of splint. You can use a wooden plank as a splint. You can use Kramer wire splint for immobilization. This is very famous Thomas splint, was used in World War II very commonly, invented by a famous surgeon Thomas. Then nowadays there is inflatable splints are also available. In modern era, you just inflate the air after bearing it, and then this will immobilize the part. In cervical spine injury, the head halter is a commonly used traction method for as a primary treatment. If you don't have such a type of splint, then you can use, if there is a fracture forearm, you can use a folded newspaper. But you should not tie this bandage very tight. It should not be very tight, otherwise they will develop a neurovascular problem. Or you can also, foot rule can also be used as a splint. Pillow can also be used as splint. Wooden plank, I have shown you for a fracture of leg bone. Even a bamboo in villages, if bamboo can be used as a splint. Or if you don't have anything, umbrella can be used. But you should take care that this bandage should not be very tight. For upper limb, this triangular sling is very commonly used. Then what are the options for, if you cannot reduce it, or you can, after reduction the patient, the reduction is not stable, then what we will do? Then there is the operative methods of treatment. In open fracture, the external fixation is, if the grade, if the lot of soft tissue trauma, the external fixation is the option of choice. And then if the fracture is closed or is grade 1 or 2 open, then you can go for an open reduction in internal fixation or by intramedullary nailing. What are the AO principles of fracture treatment? Anatomical reduction of the fracture is essential. You need a stable fixation. You should preserve the blood supply. Soft tissue, you should not damage, strip lot of soft tissue, because blood supply goes from the soft tissue to the bone. So you have to preserve the soft tissue to preserve the blood supply. Once you get the fracture is fixed, and early mobilization to allow full rehabilitation. These are the 4 basic principles. The AO stands for Association of Osteosynthesis. They have done a lot of work in fracture management in trauma, and it is followed worldwide. As I said, that you need this is what is this? This is the X-ray of the knee. There is a fracture line going like this. This is a joint. Fracture is extending up to the joint. If the fracture line is extending up to the joint, you have to do anatomical reduction of the joint, either by simple screw or by a plate. The fixation should be very stable. You see, this bone is fractured over here, is very unstable. Even he cannot move or take side turn, there will be pain, is very unstable. And then it should be, so you have to fix it. Fixation also could be unstable. If you apply 3 screws here or 1 here, this fragment will rotate. And 2 screws is little more stable, but if at least 3 to 4 screws on each side of the fracture gives stable reconstruct. Many times, then there are methods of preserving blood supply by, there is a special plate. This can be done by reducing the peripheral stripping, attempt of indirect reduction whenever possible, or by selection of implant that preserves blood supply, like LCDCP preserves the blood supply because there is a space between, and then locking plate, this is the bone, this is the plate, there is a space is left for periosteum and soft tissue from where the blood supply reaches to the bone.